Okay, so I think we'll go ahead and kick off the next session. And it's my pleasure to introduce my boss, my mentor, who's really helped so many of us in the field of interventional cardiology and has sort of helped drive the space forward with evidence-based medicine and really sort of with the goal of sort of his focus has been improving patient care, but also improving the transmission of knowledge through meetings throughout the world. And he's always given his time generously. And he's been here to this meeting in the past. Unfortunately, couldn't join in person this year, but Marty has agreed, able to join us virtually. So, Marty, can you hear us?
I can hear you very well. Yes.
Perfect. Well, welcome. It is rainy here in the middle of a cyclone. There are floods outside in the streets a little bit, so it's impacted things. So weather elements everywhere, I guess, both in the U.S. and around the world, sort of make some of these challenges of people getting together difficult sometimes. But thank you for joining us, and love for you to say a few words, and then we'll move on with the rest of the session.
Thank you very much, Sushil. Well, the weather report from New York City is 95 degrees, very humid with the possibility of thunderstorms. So it's not so different right now than in Mumbai. Well, first, it is a huge honor and a privilege to be part again of TCT India, now 2023. Sushil and I have worked closely together for now 20 years. So I'm not his boss. We are friends and very close colleagues. There's a great mutual respect. His commitment to this course and to education in India is remarkable. And I think all of his friends join in trying to celebrate the importance of maintaining this close relationship. I have had the wonderful opportunity to be part of TCT India many times in Hyderabad, and hosted by our great friend Srinivas Kumar, who is a wonderful human being and a great interventionalist and a remarkable host. And I crave the opportunity in the future to be able to be there in person again and to share experiences and friendships and knowledge with our colleagues. We learned so much from each other. We've been through a very tumultuous period with a pandemic for the past 3 years. Now we're coming out of it. It's making life a little bit easier. Traveling is still somewhat complex, but I think we have to force ourselves to try to restore the in-person dynamic that's allowed this very dynamic field of interventional cardiology to progress and grow over the course of now more than 4 decades. So we're excited to see each other again. I am truly privileged to declare TCT India 2023 opened. There'll be important and meaningful live cases and didactic discussions and debates and conversations and case reports and presentations on innovation between now and July 29th. So you'll have a very full and very interesting program. And I'm sure everybody will be enriched by that. And then finally, I'd like to extend my welcome to all of you to join us at TCT this year. We'll be in San Francisco. We expect to have a full and very dynamic meeting with a lot of late-breaking clinical evidence and, again, many live cases. And it's always an opportunity for us to get to know each other better and to share and exchange our ideas, which really has been the signature of TCT, which is its intent to try to create a global community of interventionalists so that we can continue to learn and benefit from each other. I'm hoping sometime soon to return to India. And I'm excited to be part of this meeting, even if it is largely a virtual opportunity. So with that, I'd like to go to what would be my opening lecture, which for me is a little bit of an unusual lecture. So I think you can all see that.
Yep, we can see them very well.
Great. So I gave a lecture recently at the PCR meeting talking about the 3 big things in interventional cardiology, predicting the future. So this is a little bit of a derivative of that lecture with a slightly different focus, but I think it's good for us sometimes to take a step back and to try to think about where we're going as a subspecialty, and even to predict what the future might look like. And that's one of the things that I'm going to try to do in the next 12 or 15 minutes, to talk about the future of interventional cardiology. Of course, this includes structural heart disease and endovascular intervention as well, because the principles are the same. And I think it would be interesting for us to have a discussion at the end to for me to gain some of your perspective on some of these concepts. These are my relevant financial disclosures, which you should all be aware of. And let me begin by showing a picture that I show very often. This is my good friend and colleague, Alain Crebier. We've worked together now for 25 years in the space of transcatheter aortic valve replacement. And this is the first case that he did on April 16th, 2002. And this is a man in his 50s who truly was a compassionate use case. He had been in cardiogenic shock 3 times, refused for cardiac surgery, had a previous pneumonectomy, pancreatitis, severe peripheral vascular disease, so there was no access, retrograde, transaortic, and they had to do this case transeptal antegrade. And as I said, he has been in cardiogenic shock multiple times with recent failed balloon aortic valvuloplasty. His pathology was aortic stenosis, but it was a bicuspid valve. He had profound LV dysfunction with an EF of 10%, a mobile LV thrombus. And this procedure was done without transesophageal echo and without general anesthesia. And this is 15 minutes after the procedure. And this was truly the first case done, and it was the proof of concept that you could, on a beating heart, in a closed chest, a transplant, a bioprosthetic valve in the aortic position, and sustain, at least for the short and midterm, normal aortic valve function. And that was a remarkable achievement. I spoke to Alain a few minutes after that procedure. We had a phone call because we had been conversing intensely about this case. And he was excited, but also was confused about where to go next. And we've had some interesting discussions. And I will say that none of us could have imagined that from this first case, we would have evolved to the point where there are approximately 100,000 of these procedures performed annually in the United States, with continued growth and a remarkable impact on the management of valvular heart disease. And it spawned a whole new series of technologies, transcatheter technologies, in the structural heart space. So it was difficult to predict the future, but with a combination of iterative technology and evidence-based medicine, we were able to generalize this technology, teach many physicians to use it, and it's had an important impact on the space. So starting from this case, you wonder how many more of these kinds of breakthrough technologies will be available to us. Well, so when I thought about this, I said, look, I'm not as smart as artificial intelligence, so let's ask ChatGPT what's going to be the next innovations that's going to impact our field. And it's exactly what I did. And this is the response that I got. As an artificial intelligence language model, I can suggest some of the biggest potential disruptions that are likely to happen in the field of cardiology in the future based on the latest trends and developments in the industry. And these were the big 5: personalized medicine, telemedicine, artificial intelligence, wearable technology, and gene editing. So this is what the prediction is for where cardiology is going in the future. And I can say that interventional cardiology is going to incorporate many elements of at least 3 of these things, certainly personalized medicine, no question, artificial intelligence, and as well, I believe, wearable technologies as well, or physiologic sensors. I would generalize it even further. So clearly we're in step with where the general field of cardiology is going, and it doesn't really involve a single device development program, but it's a much different process. So you ask yourself, what about good old-fashioned medical devices? Which is what we've been schooled on for over 4 decades. I believe we're really at an inflection point. that medtech of the future is rapidly evolving to an elevated platform wherein we have to be conscious of cost-efficient healthcare models. These must be respected. Certainly, it's even more of a consideration in India, where some of the technology is not as readily available. So the cost-efficient presentation of technology is crucial. Device development can't just account for the normal case, but it's got to account for the range of anatomic subtleties, complex pathologic changes. We've got to be able to appreciate physiologic considerations to address and define not just a clinical need, but the most compelling, and prioritize what the clinical needs are. Every big breakthrough will be enabled by at least 4 things. Advanced imaging and simulation, you're seeing that. You just heard about a zero contrast PCI being done. The concept of data science, and in the future, pragmatic clinical trials. The whole digital health revolution that is ongoing and extends in many directions. And all of this empowered by artificial intelligence and machine learning applications. So the keys to success in the future will be creating a new medtech culture, which emphasizes some of these enabling concepts and allows us to both integrate and develop new processes. Medicine is changing, and we have to learn how to manage the changes in medicine because they have an impact on the future of interventional cardiology. And a lot of it has to do with us being more proceduralists as opposed to therapists. And we have to better learn how to manage the continuum of healthcare, which begins with the early identification of risk factors and accurate diagnosis, progresses to overt disease and symptoms that requires treatment. But there is a continuum of healthcare. For us to be effective, we have to intercede with interventional techniques, which must be cost-effective, that should be preemptive, using the least invasive interventional therapies that can be generalized and standardized. By generalized, it means that much of the physician community who is properly trained can use these devices, and standardized, sometimes enabled with things like robotics. The goal is to achieve faster recovery, better procedural outcomes in more patients, trying to reduce the variance in patient outcomes. Early hospital discharge is a main consideration because many of these procedures, in fact, won't even be performed in the hospital. They'll be in ambulatory surgical centers. And then once the patient is home, to keep the patient at home using a variety of monitoring techniques. In order to be able to do this, we have to predict the responses to therapy, and that gets into this personalized medicine, to be able to better predict what the outcomes are going to be, and to improve access to care, recognizing that continues to be one of the major concerns, both the underdiagnosis and the lack of availability of what have been proven therapies, at sometimes in the setting of critical disease. So what would be a case study? And I've shown this slide before, and I'm talking now about aortic stenosis. And I've spent 25 years thinking about this middle box. How do we develop a transcatheter version of AVR that would be more of a minimalist procedure? How can we enhance the technology to make it predictable and as good as a surgical device, maybe even better? How can we expand the indications? To do that, you've got to develop clinical evidence and do clinical trials. And all of us feel that that's a sacred component of this. And we have to respect patient preferences. And shared decision-making means that we allow patients to help determine the healthcare process. But we have focused on the index AVR. And what I'm telling you is at least as important as actually doing the procedure is what comes before, what we call the upstream effects. We have to improve the diagnosis of aortic stenosis. The current echo techniques are anachronistic. We're developing new AI and deep learning algorithms using common ECGs. There are biomarkers. There's AI interpretation of imaging on echoes that's going to become readily available within 5 years, performed by sonographers that are going to be easily trained using AI to obtain the best quality studies. This is all going to change. That's going to change the potential for access to care. That's going to dramatically increase the number of patients who might be candidates. Remember, in the US, which is thought to be a progressive society with access to care, at least half of the patients with diagnosed severe symptomatic AS are not even treated in the first year. We believe that the trigger for treatment has to shift. It can't only be the fact that a patient wakes up one day and says, I have symptoms. There have to be better predictors and better markers or triggers for therapy. And that gets into the concept of preemptive AVR and defining disease severity, not just based upon hemodynamic gradients, but also using other staging techniques that we have helped to develop with others. We also think that there's going to be a role for medical therapy, and we're now into a whole new range of new medical therapies that are going to initiate a whole series of clinical trials over the next 5 years to delay the progression of calcific aortic valve disease. So it's not enough to say as a proceduralist, I only do the procedure when the disease is severe enough that it requires treatment and I forget about everything else. I think you have to be concerned as a physician therapist about what happens before. And equally, you have to be concerned about what happens afterwards. So you have to be thinking about valve durability, therapy sequencing in younger people when a biologic valve fails. How do you manage concomitant cardiovascular disease? A full third of patients with severe aortic stenosis have significant other concomitant diseases. And to be able to manage those takes a whole new series of algorithms and treatments. And then in patients who are non-responders, and that also involves a significant minority of patients that don't feel as well as you would predict or like, we are developing adjunctive pharmacotherapy to be able to manage those patients. So this is a good case example of the continuum of care process. So as interventionalists, at least I believe that you need to understand more about what's happening beforehand and afterwards from the standpoint of how to manage these disease processes. Now I'm going to show you a whole series of examples, and I could have picked many different examples, but I'll show you some that I think are interesting that may be part of our future in terms of predicting where interventional cardiology is going. I've been working with colleagues in Israel, in Jerusalem and Tel Aviv on microsensors for the past 15 years. And we finally have developed a microsensor, which is sub-millimeter in size, which you see on the left, which is passive. It doesn't require wires, doesn't require batteries. It is activated by frequency-tuned external ultrasound, and it can be implanted as a sensor itself to measure pressure. But it also can be part of other diseases, and it provides a signal that looks like what you're seeing on the right here, and that is an implantation in the left atrium. Now, we've demonstrated this in animal models, and we are demonstrating how easy it is to implant one of these as a standalone device, much like with cardiomems being done in the pulmonary artery, but this is a far more advanced technology. So we believe, and this is going to be starting human clinical trials as well. But the real future of this is that this can be incorporated on almost any device. I couldn't imagine that you would put in an interatrial shunt device and not wanting to know what the pressures are on the left and maybe even the right side. We implant left atrial appendage occlusion devices in patients with atrial fibrillation, a significant minority of which have evidence of heart failure. It would seem obvious that this would be another opportunity. These can be incorporated into valves. You can actually measure the gradient across the valve using these kinds of devices. So the idea of creating dynamic smart devices to enable new technologies, implantable technologies, is not so far in the future as you think. Another example. Well, we have been struggling for about a decade with transcatheter mitral valve replacement. It's not as easy as aortic valve replacement, and I'm not going to get into the reasons, but it's been complex. Functional MR is a very frustrating disease. Even if you look at a trial, which is like the landmark trial, the COAP trial, we just saw the 5-year follow-up. The 5-year follow-up in the treated patients, successful patients treated with MitraClip at 5 years, 75% were dead or had recurrent hospitalizations. I don't consider that to be such a great therapy. Well, this is an interesting version of a new TMVR system. It's called InnoValve. There have only been about 30 patients in the world that have been treated with this device. And what it is a standard bioprosthetic valve, but it has these hooks on the frame. They engage the chordal apparatus. Then you rotate the device, and that causes tension. And that tension brings the basal annulus together. It creates a basal ventriculoplasty. It creates approximation at the annular level and at the papillary muscle level, and also lifts the apex as well. Plus, it tilts the valve in a posterior position, and then it restores bidirectional flow, which is something that is not seen with other TMVR systems. And you're seeing a whimsical example of what the normal flow should look like in a left ventricle. So if this is really working, it not only replaces the mitral valve, eliminating MR, but it also has the potential of remodeling the ventricle. So let's look at some of the data. You normally expect when you put a mitral valve in that the EF either stays the same or goes down. This is the EF in all patients. At around 6 months, about a 7% absolute increase. And those patients with a baseline of less than 40%, a 15% increase in ejection fraction. And if you look at LV remodeling by echo or CT, you see striking changes in a relatively short period of time. So yes, with careful thought and trying to integrate principles and a better understanding of the pathology, we can develop devices that are going to be dramatically better than what we've seen in the past. Another example is this, because everybody wants to develop a TAVR valve. This happens to be one that's being developed by Anteris, and Sushil's familiar with this. He's actually worked with this device. This is the Dure VR THV. It's a biomimetic design. So the valve leaflets are shaped like a normal human aortic valve. From a single piece of anti-calcified or decellularized pericardium that has been engineered and processed. It has longer coaptation lengths, open large cells for coronary access, and the initial results indicate much improved hemodynamics. And if we look at it using sophisticated imaging techniques like CMR, you're seeing in the bottom right, there seems to be normal aortic flow, not just at the valve level, but beyond, and also behind the leaflets. So this is an interesting development that may have important implications on acute hemodynamics and on late durability. Another example. Now let's move away from structural for a moment. I have been struggling with being able to do more precise PCI, or what we call precision PCI, for multiple decades. We did some of the first intravascular ultrasound work in the coronaries, obviously, and have been involved in imaging and physiology for a long time. At Columbia, 90% of our PCIs are done with imaging or physiology, generally IVUS, but also OCT. This is an example of a system developed by a company called Clearly, which is a CT-based system, which is completely AI-enabled, which shows you not just the lumen, but shows you the plaque distribution, shows you the plaque morphology, whether or not it's calcified, non-calcified, whether or not it has fatty components, and gives you tremendous anatomic delineation of the architecture so that you could plan a procedure. It also has built-in predictive models to say that given this plaque distribution and the narrowing and the morphology of the plaque, this patient would be better for surgery. You should increase the statins. You should adjust a variety of other things in order to optimize this patient's therapy. This is the kind of thing that we're going to be doing in the future. Another version of that, which is completely AI driven, are some of the new OCT systems that allow us to do automated calculation and predictions and modeling about how you should approach a specific lesion with a single OCT run. So precision PCI, I think, is definitely going to be changed in this new modern era of intervention. Now, I'm sympathetic. You're a busy interventionalist. You want to get in and out of the lab quickly. You don't have the time to take CTs beforehand and plan procedures. It gets too complicated. This is something that we're now enabling in our lab right now. This is the CathWorks system. It's an AI-driven system, and this will increase your procedure time by 3 minutes. You take 2 or 3 different views, and we've been developing this for about 8 years. It is now FDA approved. We're just beginning a 2,000 patient study. After you develop these views, it immediately constructs a 3-dimensional coronary tree, and using electrical resistance algorithms, shows you a flow distribution map of the entire coronary tree from your standard angiograms. You can do this during the case, after the case, to see if you're finished. You can decide how to treat tandem lesions, diffuse disease, branch vessel disease, bifurcations. And this takes an extra 3 minutes. And we're doing a validation outcomes trial to see how this changes outcomes if this were incorporated into routine treatment. And this is completely AI driven. Now, you've heard a lot about heart failure, and I still believe that interventional heart failure is going to be a major force in the future. Certainly, heart failure is a final common pathway for many of the diseases that we treat, whether they're ischemic vascular or structural. And the way to manage heart failure is going to change. It is changing. And part of it has to do with identifying the non-responder phenotype, patients who are still sick or episodically sick. And there are ways to do that with ambulatory diagnostics, outpatient monitoring, point of care imaging, all kinds of things that are being developed right now to be able to help us to identify the non-responder. We put a MitraClip in and we feel good about ourselves. Yet the patient comes back in 3 months and still is very symptomatic. Identifying that patient, being able to engage in what is now better guideline-directed medical therapy, and to monitor that with other than just symptom response is going to be an important component in the future. So this integration and process change that I've been describing is all about having data, acquiring data, transferring it, analyzing it, and then after you analyze it, to come up with clinical solutions that are interfaced with specific patient care interventions. And that's going to make the difference. So you might ask yourself, well, but what about me? I'm the physician. Where do I get in this? Well, the reality is the solution derivation after you analyze the data is very much, in fact, it's almost entirely driven by healthcare professionals. So we are essential components of this cycle. So we need to become part of this. We can't sit on the sidelines, but we need to develop a way to be able to integrate with these systems. Now, I still believe that there will be new platform technologies that continue to transform interventional cardiology. And I'm going to show you one. And I was at an electrosurgery summit a couple of months ago. And this is a whole new field of transcatheter electrosurgery. It's been developing slowly and now rapidly at NHLBI, at the NIH. And this is a field that allows us to be able to not just modify anatomy, but to significantly change your ability to modify specific structures, either to assist therapy or to be definitive therapies. So why is this exciting? These are small, flexible devices that can access almost anywhere in the vascular and cardiac system. They're safe. They're only sharp. They only affect cutting when they're activated. They're reliable. It's cutting rather than tearing tissue. And now it can be attained with off-label devices, and we're building a variety of purpose-driven devices several companies are becoming involved in doing this. How do we do this? Monopolar RF using standard generators, where the charge is concentrated with focal insulation that vaporizes tissue with electrosurgery rather than heat with electrocautery. And what has it resulted in? These are 15 distinct therapies that have been developed using transcatheter electrosurgery techniques, many of which I'm sure you're familiar with. Transcaval access was one of the early ones that was developed. The basilica technique to modify the aortic leaflet that allows you to have access to the coronaries to prevent coronary occlusion is another interesting and important one. A similar version of that, something called Lampoon, which modifies the anterior mitral leaflet, which improves your ability to perform TMVR in patients that require that. There's a new therapy called Sesame. Sesame is an LV myotomy that can be done using electrosurgical techniques that has been applied now in approximately 80 patients worldwide that I believe will become the definitive treatment for obstructive hypertrophic cardiomyopathy in the future and has implications in other disease as well. And a version of that is called Mirth, which is to be able to install a variety of wireframe devices to create ventriculoplasty in patients with heart failure. So breakthrough technologies will still happen. Platforms like this can be developed, and it's astounding to me what the capacity of interventional cardiology will be going forward. So some final thoughts. I think some of the next big things should be this tectonic post-pandemic shift in thinking and culture, which will accelerate the transformation of medicine and in parallel interventional cardiology therapy development. Unless we are in step with changes in cardiology, we will be behind. It's got to be sensitive to changing healthcare models, responsive to complex pathobiology, patient-centered, personalized, and generalizable. It's got to be usable by most physicians, not just the chosen few. It will be driven by data science, digital health, and artificial intelligence engines, and it will transition from a procedure focus to a disease state continuum approach. And this is all just beginning. So fasten your seatbelts. So my last slide is my response to Alain, which is that, almost 25 years ago, he came up with a brilliant approach, and we all marvel at what a difference it's made. But I would argue it's just the beginning. So when he asked the question, what now? I think we can respond by saying there's lots more to do. And I think that the future is very bright in both interventional cardiology and structural heart disease. Thank you very much.
Thank you, Marty. That was a brilliant sort of look into what you envision as a future. I'm sure there are a lot of questions. Just a couple quick questions or comments. I mean, a lot of what you talked about will hopefully democratize the delivery of medicine. Right now, I mean, when we look in India or we look in West versus Europe versus things, there's a lot of things where there's a lot of variability in the care driven. Do you think AI, do you think technology will allow a more, I guess, level playing field for delivery of healthcare, or is it going to just separate it more because there'll be or is this going to add more cost or more things to separate the strata more?
It's a great question, because whenever you have potent technology, it can be used, abused, misused. But I think that AI does have the opportunity to be able to create a level playing field. And I tried to use that example, Sushil, of how to diagnose aortic stenosis. We're still diagnosing aortic stenosis the way we did, 50 years ago. We haven't done it any differently. The ability to be able to have a handheld echo system that is point of care, where the operator, I'll say the sonographer, but it's more the technologist, can obtain an echo using AI that teaches them how to get the necessary images, then to have it read by AI image interpretation algorithms that, by the way, are probably more accurate than human reading. And right now, some of these algorithms are reading full echoes in less than 2 minutes and coming up with a diagnosis. That to me is transformational. That you take into the field, that allows you to begin screening patients. And then if you even go one step further and say, well, with an EKG using AI algorithms, we can pre-screen the patients that are more likely to have AS, making that a two-step, more cost-efficient process. I think it does democratize the ability to understand what is the target patient population and to prioritize who needs to be treated more quickly. But that's a good example of how AI can be used correctly that will help, certainly us in the US, but even more so in countries like India.
Any comments or questions? So, go ahead, Srinivas. Yeah. Oh, here. You want to use this mic?
Thank you. Great visionary talk, Marty, and always intrigued by facts which you run through. Last time when we met, you said upstream aortic, moderate aortic stenosis therapy. Now catheter-based, then electrosurgery, and many more new things we'll get to learn. That's why we are always wanting you to be part of this, and always you introduce some new things which really matter to patients. I think we're extremely thankful for that. And in India, one of the stall in the industry is a digital heart failure clinic, which they just launched. One of it you mentioned. So we are that's a great step towards monitoring patients and providing personal heart treatment to these patients who suffer with heart failure, along with other newer therapies like sensors, other things which you mentioned. And
Yep.
our Prime Minister Modi said, AI in America and India together we can do great. But you gave a lot of importance to AI, and both our collaboration should do more good to patients in general and also particularly in India. I think we have a surgeon, Dr. Gokhale, just joined. Please come onto the podium, please. And we have Dr. Ajit Pulasari, sir, and Dr. P.C. Rath. P.C. Rath, sir, is the president of our association, sir. So he'll have his comments too.
I think, as you correctly pointed out, that artificial intelligence is going to change the scenario of healthcare all over the world. We are looking to see what is happening. In the field, we are seeing some changes in imaging, small subtle changes, but then big change, I think, is going to come in next 5-10 years. And we are looking forward for change in the way we look at healthcare. I think it's going to be more digitalized, more personalized, and more focused. Thank you for your very, very thoughtful talk. Thanks.
I agree. Those were great comments. I agree completely. And it's hard for us to change, but we have to approach change, and these kinds of transformational changes with excitement. And unless we are in the arena, then we'll be left behind. So we have to be part of the change and to make sure that it gets democratized and it's used correctly. And physicians are still directly involved in how such potent technologies can be applied.
I think one point that's important is, Marty, you mentioned that, physicians have to stay involved. And I think there's a lot of fear, like in the auto industry, the workers feel robots because they take away jobs. We sort of fear this because what is our role and what level of trust do we give to these AI algorithms? Because if we don't trust the algorithms, the patients won't, because patients invest a lot in their physicians. But there is a point where the data is too much and it has to be the algorithms that tell the patient what to do. They look at night and the algorithm is going to say, take an extra dose of Lasix or your blood pressure, or you need to see your doctor. That's a big leap of faith, because the patient forms relationship with the physician. And how do your point is incredibly important that we have to embrace it. We have to drive it, because if we don't, it's never going to succeed, because patients won't have the confidence in it to start. And I guess that's where I struggle, because it's the inherent fear. It's the same thing that we all fear what we don't know. And Chat GPT is a perfect example. You said it, and people sort of joke about it, but it's real. And how do we use it ourselves?
No, that's a great point. I mean, that's one of the, most important, issues that we're dealing with right now. We're doing a 2-day webinar on the use of artificial intelligence in valvular heart disease in November with about 70 data scientists from around the world who are interested in this space. And one of the big issues that has come up in putting the program together is to overcoming the lack of trust in AI. How are we going to develop the trust that these algorithms really work and that they're telling us meaningful things? And if the physicians can't trust it, then obviously the patients are going to have a great deal of difficulty. And it's part of a space that we've been calling implementation science. And I think that's going to be the big focus, that we need to be able to work together to be able to develop these models so that the information that we get, this overwhelming amount of data, is translated into things that we can understand and we can apply and we can demonstrate in clinical trials are working. So I think that's a big step, and that's a step that's going to be ongoing for the next more than 5 years. So you're completely correct. We've, got a very powerful technology. We don't quite know how to use it, and we're going to have to figure out how we can both use it correctly, gain trust in it, and then communicate that trust to our patients.
And I think one point along that side that we have to sort of help develop in the beginning. I mean, it's the ugly side, part of the side, but the finances. If you start using AI to take away testing that people are doing, that's part of their business model. When they see patients, but all the stuff that the AI is doing is unreimbursed time on the physician side. It will be hard to get buy-in from the physicians to work with the regulators early on to figure out what the reimbursement structure for this data management is. That where you're not directly contacting the patient is going to be an important component. I know CardioMEMS and those have done that to an extent, but I think that's a critical component, especially and it's going to be different models in the U.S. versus India. And I'm curious what others think about that as well.
Yeah, thank you, Marty, for a lovely lecture. I think I absolutely agree with you that artificial intelligence is going to democratize the process rather than make it more the divide being wider. I can say a few examples on this. A simple EKG, which used to diagnose ST elevation and non-ST elevation MI, which is what most physicians decide to treat patients, to send them to cath lab or no, is now being delivered by AI very nicely. There was a Nature Medicine paper which just looked at simply the EKG and decided which is occlusive and which is non-occlusive. And the occlusive guys, whether it's non-ST or ST, goes to the cath lab, and the non-occlusive guys still remain with medical treatment. So it's a very simple tool based on a simple EKG, AI-derived, and it's being validated very strongly and published in Nature Medicine. So you just need 20 seconds, and any physician anywhere can use that tool and say, send to the cath lab or treat in the nursing home. Cath Networks is another simple technology. I don't need to do an angiogram, wait, get a QCA, drop an FFR wire, spend all that money for the FFR wire, and then say, okay, tomorrow morning I'll tell you whether you need to stent this or not. In, say, you said 3 minutes, it could be 20 seconds. So you can make that decision on the table without spending all that time and money. So I think these are absolutely what's going to happen in every area. And I think there'll be only 2 types of physicians: physicians who know AI and physicians who don't know AI. AI will not take away the jobs, but physicians who don't have AI knowledge will have no jobs, I think.
But one thing,
so that's a big theme, and there's no question that that's going to be a big theme in terms of what we do. And it's been one of the central components of this lecture, and I'm convinced it's going to be part of our futures, like it or not. And I just think that I mean, the other part of that theme is that I've been so focused on the procedure in the cath lab. Well, you all are. You're interventionalists. There's nothing wrong with that. But there's so much more that we have to be thinking about before the patient gets to the lab and after the patient has a procedure that I think can radically impact their overall care continuum. So I think that I would just encourage everybody to not think of ourselves as just proceduralists, but to really consider both what we've been calling the upstream and downstream effects.
ChatGPT is being widely used to write articles. I'm editing a book, and as one person told me 90% of the article he wrote using ChatGPT. Is it going to change the way we are writing the articles in the journals?
That's a great question. I don't know. I think that we'll use ChatGPT in a smart way where we can try to make ourselves more efficient in terms of how we write articles, and I'm sure that they can collect the literature in a more efficient way than I could. So I think in some respects, I think it will make us more efficient. I hope that we never learn that we never lose our ability to communicate, and writing is part of communication. So I'm a great believer that we still have to maintain some control over how we express ourselves. So ChatGPT will help, but I don't think it will replace, I think, the human element. And so much of what I see in articles is not just the data, but I always look at the results of a study, but to me, as important, of course, is reading the discussion. And that really is not ChatGPT. It's the analysis of the data, and it brings in a variety of factors that currently can't be replicated by AI alone.
Marty, thank you very much. I think you touched base on gene editing. So
Yep.
Sushil and I are probably, or some of our audience who have migrated out of India to United States, are a little bit, not exposed to the premature coronary artery disease. As we see in India, almost every 3 months, there's a young physician who's dying of plaque erosion or plaque rupture. Do you think, as Ajit mentioned, is the AI going to predict those type of normal ECG and predict the probability of MI? Or will it be gene editing that will, at least in our lifetime, will we see gene editing to reduce the risk of MI in the young people?
I am fascinated by what gene editing promises to be able to do. It's pretty much overwhelming, but we'll see in the next 10 years. I think there's been some exciting work done, and I think it's going to affect heart failure, and it's going to affect premature atherosclerosis in young people for sure. But I would also argue, we did a lot of work trying to look at vulnerable plaque. You remember a decade ago, that's all people could talk about was vulnerable plaque and how to predict it. We developed all kinds of tools, thermography, imaging tools, and whatnot. And we were marginally successful at predicting the patients that were likely to have plaque rupture and coronary events. I tell you, the one technology that is more promising is this CT technology from Clearly, where they really, because they're dealing with thousands and hundreds of thousands of patients, and they're now doing 4 large randomized trials to look to see if there are any patterns on the CT scan in terms of identifying plaque phenotypes that predict things like plaque rupture and coronary events. So if I would think of one technology that I feel has the best chance, it would be CT, of helping us to identify the at-risk patient among those young patients with premature coronary atherosclerosis.
So Marty, on that note, at what age should I get my CTA, or should I have already had mine?
You should have already had it, Sushil.
I guess that's the question, right? With the screening, I keep debating it, but how many on this podium have had a CTA?
Yeah, everybody. So here,
Okay, about half had it, Marty. Half had their CTA.
one new study is studying role of chest X-ray in the artificial intelligence to predict the same information which you get on CT angio. One thing good, Dr. Marty and Sushil, is probably AI or Chat GPT can aid us in diagnosis, but obviously they cannot play a role in intervention or Gokhale's surgery. So I think as physicians, our role in treatment, as well as also reassurance and the human touch of patients in treatment is very important. I feel that
Very important.
yeah.
Very,
Thank
I so much agree with that. Yes, that you've always got to be able to find the time to sit down with the patient and to, and to, create that bond. And I will tell you that among you, people like Sushil, Ajay, who well, really, that's a fundamental component of the way they practice medicine. So there's much that goes beyond just doing a procedure or talking about technology, and I would hope that those human elements are never extinguished by all of this technology.
It's just like the physician from Stanford, Abraham Burgess, said there are two patients in your clinic. One is the virtual patient whom you're seeing on the computer, and there's a real patient lying on the bed whom nobody is seeing. And I think this is what Srinivas is saying. If you become too technology dependent, you just ignore the real patient and you're looking at the virtual patient. And I think that's very important.
Yep.
And if you are talking of the human touch in treating the patients, all this is evolving. See, sometimes some patients may prefer to listen to music rather to the words of a doctor. That is also there these days. Not that everyone has got a human touch, but I'm sure as we evolve, even the machines will evolve and they may be talking better than most of the doctors too. I may be just doing only a physical touch.
No,
Yeah.
Go ahead, Marty, sorry.
No, it's an interesting point. I think you're right. There may be ways that some of these smart machines are going to be able to communicate better with certain patients than we do as physicians, but we'll learn. I don't want this to be taken as that, a departure from the importance of procedure-based medicine. But I just want to put it in perspective that there are so many things changing around us that those procedures are going to change. The way we analyze data is going to change. The way we interact with patients is going to change. The way we develop new devices is going to change. The way we do clinical research is going to dramatically change. And we've got to be prepared for those things and do our best, not to be offended and not to be confused, but to try to, learn how to adjust to some of these changes, which will occur very rapidly over the next decade.
I think Dr. Frank,
yeah.
question? Yep.
Yeah, Martin, warm greetings here from Mumbai to you. I would like to ask you, according to the patient's compliance, as you know, there's a part in every society, wherever you take a look, in Germany, in US, in India. We saw this according the COVID-19 vaccination. And in Germany, we have around between 15 and 20% of people, even well-educated people, they wanted now to get vaccination. So they are against vaccination. And believe me, this is a problem in our society. Even if you have information, there is potentially very aggressive, deadly infection. Some part of population, they even don't accept this. And what do you believe personally? What is the solution to bring this 15–20% of patients, of potential patients, to 100 topic?
Well, that's a huge problem. And, fortunately, we live in democracies, so patients will always have the right to decide what kind of care they're given. We can't force them to be treated. And the reality is, part of this is what Sushil said, that the patients have to trust the physicians and trust the technologies and trust the therapies. So we have to somehow build that trust. I naively think that, yes, there are a lot of people that are misinformed, and that the combination of social media and a variety of other sources, has distorted our ability to communicate accurate information. But the physicians have to be the ones that are transmitting the message. Unfortunately, some people won't listen, but maybe over time that, we can develop, and maybe it'll take a generation for people to become more compliant with therapies that we know to be safe and extremely effective. And I think that there can be incentives that will encourage people to follow what would be a more correct path in terms of a treatment and other things. But it's human nature, not to have a uniform response, unfortunately. And what you see in India, we see in the US as well. I don't know that AI alone is going to overcome that, but I think that if we make the care more personalized, I think part of it is that we're almost antagonistic with the patient, and that disease is a bad thing. People want to avoid bad things. Physicians represent disease for the most part. So there's a physician avoidance concept that needs to be overcome. If they become more involved in the care process, and if preventative medicine becomes the routine, then I think you can break down some of those barriers of antagonism and get people to be more compliant with what we think are the appropriate therapies.
I think there are opportunities for technology to help with compliance as well. I mean, just sort of by being there all the time. And also there may potentially be reimbursement models in the future where patients are paid and actually make money. There are models that, companies have tried where they pay extra when people exercise, or pay extra when people wearing an Apple Watch to identify disease early. So there may be models and reimbursement that actually help society and that also help the patients as well. And are there any other questions from the audience? Any comments? Yes, there's one question out there. Please go ahead.
Thank you, Dr. Martin, sir, for such a wonderful peep into the future of medicine. I have a small point or comment to make, and in a way, I wanted to say that the AI is based upon the digital processing of data, and it involves the collection of data, making it structured, use of digital languages like Python and all, and then machine learning, and finally developing the algorithms which become artificial intelligence and which are helping us in so many ways now. So as part of a basic medical curriculum, is it worthwhile to include some kind of a training of these digital languages, so that we as physicians, because we have a better understanding of the domain knowledge of medicine, we can integrate the language better, and maybe we can develop, we can structure our data better, and the development of AI in medicine can be faster that way. Like earlier, I remember in India, the majority language used to be Hindi. Gradually, we had to learn English so as to become, the medical education is largely in English in our countries. So now the new language, the new basic language is probably a digital language. So should it be part of our curriculum? I just wanted the opinion of all the leaders.
Yeah, I think those are very, very good points. I don't know that we want to take all physicians and make them AI experts, but I do think that there's a certain level of understanding of AI and how to best use it that should be ubiquitous. It should be in the curriculum. It should be available in a digestible form that can be shared with physicians who are in practice. And I think that that's going to become a baseline data set that everybody has to incorporate into their thinking as they begin to use AI-driven information, so that they can be discriminating consumers of the technology. And there's another group, a much smaller group, that are really going to learn, how to develop some of these algorithms. And that the fastest growing department in our university is bioinformatics. So yes, I think there are going to be a lot of young people who will gravitate to this space as a subspecialty. And I think that that's going to become an important area of development in the future. But I think most practicing physicians are going to trust over time the value of certain algorithms that are AI driven, and will learn some of the concepts that are necessary to apply that clinically.
Well, it's wonderful, Marty. I want to thank you again. This was a great peek into your thoughts of the future, and it's a great discussion. Clearly, a lot of interest. There's a lot of opportunities with AI and integrated health that are just starting in India, and I think it would welcome a lot of this collaboration. There are a lot of opportunities and a lot of resources here. So this is just the start of an exciting new space. And thank you again for spending this last hour with us. It was a real pleasure, and everyone truly enjoyed it. And I'll see you back in New York.
Thank you all. I really appreciate it. Hopefully, in the near future, we can see each other in person. Take care.